I'd like to thank the Society for inviting me to present this. I would also like to thank Dr. Wang, who so expertly described the science behind this device. First of all, my disclosures, I'm part of the Medical Advisory Board, and the equipment was given for the study. And as was described, this is a device which is just pure heat, which goes through in a fractionated manner by using different types of hand pieces that were shown. And the way to vary the energy that's given is how long each pulse lasts. So the longer the pulse, the more heat sits on the skin. And there's a protrusion device that brings these little pyramids closer to the skin. So the closer they are, the more thermocoupling. And this is the device that was shown before. It does not ablate the tissue. It just causes water evaporation and desiccation. And we saw some of the histology that it's in this hemispherical type of shape. And the patient tolerates the heat sensation depending on these parameters. It can vary. You can use almost no anesthesia is needed, or air cooling for some of the higher parameters. And there's just a picture there. So the objective of this study was to say, since this is a heating device, does the cold application somehow detract from the outcome of the heat that is being deposited? And also, if you use, let's say, an anesthetic cream, is the hydration prior to it, does it affect some of the therapeutic outcome? And how do these two things compare to each other? So that's the goal of the study. So we did 12 patients. Those are the skin types. It was IRB approved. 7 patients had topical lidocaine for 20 minutes before, and 5 of the patients had the ice packs put on. And all had received the exact same setting. We did a periorbital area, which included a little bit of the lower forehead, double passes, 4 treatments, 1 month, and then 3 months later at the end, we took pictures and we evaluated by blinded observers. We had a pain scale of 0 to 10, and 1 to 5 is in terms of satisfaction. So these are the skin types that we had up to skin type 3. There were 3 patients. In terms of the immediate changes, all except one of the patients had a transient erythema and mild edema. One of them had persistent erythema, which took more than a month to go away. So this was the scale that the blinded observers, the top ones that had used. And what we saw that at 3 months, those using the topical lidocaine had a rating of 2.8 in terms of pain, and the ice packs was almost exactly the same. The topical lidocaine, in terms of I'm sorry, that was the first one was the improvement rating. So that was 2.8 and 2.6, almost exactly the same. In terms of the pain, they were almost again the same thing between whether it's ice packs or whether it was topical lidocaine. And in terms of satisfaction, there was a little bit more satisfaction with the topical lidocaine, but not statistically different. And the overall satisfaction was very good. We got at least a number 4 out of 5 of 75% of the patients. And just to show you some pictures, let's see if there's a pointer here. Don't know. I don't see one. So there it is. So thank you. So this is a reduction of the lines that you see there. Same thing here. This is, if you see over here, they're less. And this area here where we treat right underneath the eye, there's also a reduction. And this one, there was a reduction here, but my study coordinator pointed out to me, she said to me, look at the eyelid. She said, this line that's here is gone, and also the eyebrow has been raised because we treated right above the eyebrow. So in conclusion, both topical anesthesia and ice packs resulted in the same type of therapeutic improvement. They both reduced the pain equivalently. So the hydration effect of the topical anesthesia and the cold induced may not significantly influence the outcome. And the bottom line is that this device does improve periorbital rigidity and laxity, and it's well tolerated, and depending on what type of approach you use in terms of anesthesia. Thank you very much.